55-year-old female, weakness of right lower limb since early childhood.
Okay. So what do you make out of that?
Yes. Sir, weakness of right lower limb since early childhood. It can be an early childhood stroke may be there.
Childhood stroke, cerebrovascular accident of children.
Yes, sir.
How often have you seen this?
Very rare, sir.
Very rare. Can you say something which you have seen?
Sir, poliomyelitis.
Polio can occur like this, yes.
Yes, sir.
What other neurological problems you have encountered?
Then Coda-Equina syndrome can be.
Okay, you have seen. What about cerebral palsies?
Cerebral palsies, usually bilateral.
Usually bilateral, correct. Okay. So you have put some differential diagnosis here. Would you like to know more about this history?
Yes, sir. The patient initially walked with support. Weakness increased following her last childbirth. Not able to walk at all. Crawls over the ground. No sensory complaints. No bowel and bladder incontinence. No wasting or fasciculation.
So, can you go ahead with each step?
Yes, sir. Initially walked with support. Now weakness increased. That is a progressive illness. Gradually progressive.
No, it did not gradually progress. Actually, one episode of progression. That's all.
Yes, sir.
Okay.
Yes, sir. The weakness increased following her last childbirth.
That's right.
That means some. Yes, sir. Then crawls over the ground.
Okay.
Then no sensory complaints.
So what does it mean to you?
So it doesn't have any sensory fibers.
So which all possibilities are ruled out now?
Now anterior circulation stroke.
Your peripheral nerve is ruled out.
Yes, sir. Peripheral nerve is ruled out. Yes, sir.
You ruled out the root problems.
Yes, sir.
You have ruled out the spinal cord problems.
Yes, sir.
You have ruled out the sensory tract and sensory cortex, no?
Yes, sir.
Yes, so some possibilities are not there.
Yes, sir.
So disease affecting those parts of the body are not there.
Yes, sir.
Okay. Then no bowel and bladder incontinence.
Yes, sir. Yes, sir. It's pure motor type of weakness.
Pure motor. Okay. What else?
And then no wasting or fasciculation.
So
not element type.
Okay. Wasting is a feature of element, so you do think it is not there. Now, this is a finding on examination.
Yes, sir. On examination, patient is conscious, oriented, vitals are stable, morbidly obese, neck circumference is 37 centimeters. Yes, sir. Hip circumference is 152 and waist circumference is 145.
Yes. So
morbidly obese.
What else you would like to know?
Sir.
What is meant by morbidly obese? We have overweight patients, we have obese patients, then we have got morbidly obese. Hello? Arjun? Can you hear me? What?
Yes, sir. I can hear.
Then you tell the answer. What do you ask for a morbidly obese patient?
We are suspecting
Can you ask few questions to this patient now? What questions you would like to ask?
Yes, sir. Sir, daytime sleepiness.
That's right. 1, 2.
Then snoring during sleep.
Snoring. That's right. Snoring. Why do you want to check the neck circumference of this patient?
Because we are suspecting obstructive sleep apnea in this patient.
Okay, that's fine.
Yes, sir.
So what is meant by metabolic syndrome?
Metabolic syndrome is syndrome X. In that there is fasting blood sugar is more than 100, and there is increased in cholesterol, and there is also obesity. Increased hypertension is also there, sir.
So it is not a disease actually, it's a cluster of the following conditions.
Yes,
Abdominal obesity, high blood
Yes, sir.
pressure, high blood glucose, high triglycerides, and low HDL. All the
Yes, sir.
components need not be present in a patient.
Yes,
So
sir.
what you got here is a obese patient, that's all.
Yes, sir.
So what type of obesity they have?
Morbidly obese.
So they have what's called visceral obesity. The fat is
Yes, sir.
specifically located in certain areas
Yes,
and
sir.
same pattern, apple-shaped
Yes, sir.
abdomen, and
Yes, sir.
usually the fat is around the waist and the hip. So these
Yes,
are the features of obesity. Now,
Yes, sir.
what's the importance of a metabolic syndrome?
Metabolic syndrome causes
It's not a
overall.
disease. No.
Yes, sir. It's a,
So why
group
should
of-
you recognize it at all?
Because group of symptoms. So we usually
So-
ignore the symptoms.
They are the candidates for getting into complications.
Yes, sir. Yes, sir.
The vascular disease, cardiovascular.
Yes, sir.
They are likely to have diabetes.
Yes, sir.
Okay. So
Yes,
it's a
sir.
combination of a triad of problems, namely insulin resistance, metabolic syndrome, and pre-diabetes, all put together create problems.
Yes, sir.
So what are the common associations of these patients?
That is hyperuricemia, fatty liver, polycystic ovarian disease. Then acanthosis nigricans will be there.
Erectile dysfunction.
Yes, erectile.
So what is? How do you recognize insulin resistance? Clinically, is it possible?
Yes, sir. Acanthosis nigricans can be there. Skin tags may be there.
So what is the pathophysiology of metabolic syndrome? Why do people get this?
Pathophysiology. Multifactorial disorder, sir.
It is exactly the reasons are not known.
Yes, sir.
Some people or becomes obese as age advances. This patient, what may be the reason?
This patient, due to decreased physical activity,
So sedentary, she cannot move.
secondary lifestyle.
So it may be related to insulin resistance, as you already
Yes.
suggested.
Yes,
Stress might be one factor.
Yes, sir.
Abnormal diet habits.
Yes, sir.
So it runs in family, so some genetics may be playing around.
Yes, sir.
Activities may be less.
Yes, sir. The
Then of
obesity. Yes, sir.
Sleep apnea is the important thing.
Yes, sir.
So what are the problems of obstructive sleep apnea?
Obstructive sleep apnea, due to decreased sleep, the patient will be irritated. Daytime sleepiness will be there. Lack of concentration.
Yes.
Then there are increased chance of hypertension.
Hypertension, very good.
Yes,
What
sir.
else?
Then respiratory distress will be there.
Agreed, yes.
Then overall, the quality of life will be decreased.
They commonly sleep while they drive. So they get
Yes,
into
sir.
accidents.
Yes, sir.
And while snoring,
Yes, sir.
socially they may not be acceptable to everybody.
Yes,
Somebody
sir.
snoring in a train, others cannot sleep.
Yes, sir.
The partner at home cannot sleep. So
Yes,
there are
sir.
social problems.
Yes, sir.
There are many issues. Social problems are there. Driving problems are there. Work environment may be again problem. They may be sleeping during the working hours. They go to sleep in between. Not their
Yes, sir.
fault. So
Yes,
there are a lot of implications. So what are the criteria for metabolic syndrome? We said certain things are there, but everything has to be measured, no?
Yes, sir. In that, the fasting blood sugar more than 100, then HDL less than 35, and then LDL level will be increased, triglycerides level will be increased, and there is hypertension also. BP 140/80, sir. 140/90.
So we have to do some clinical measurements.
Yes, sir.
So how do you measure waist?
Waist is between the lower rib border and anterior spine. Midpoint is taken as waist, and hip is the most prominent part in the buttocks.
So waist for males, upper limit 142.
Yes, sir.
Will be 88. All measurement.
Yes, sir.
There's some modification for Asians. Okay.
Yes, sir.
Triglyceride more than 150 is taken as a criteria.
Yes, sir.
HDL is something that protect you from heart attacks. So less than 40 for males, no good.
Yes, sir.
Less than 50 for females, again not good.
Yes, sir.
If it's a treated hypertension already under control, still it's a criteria.
Yes, sir.
So also people who are above 130/85.
Yes, sir.
Fasting glucose above 110.
Yes, sir.
So above 110, they will slipping on to what's called pre-diabetic status, no?
Yes, sir.
So how can you prevent this?
Prevention, proper physical activity, exercise, and then proper diet habits.
Okay, so this patient, the second possibility is possible calories may be adjusted, but increasing physical activity may be tried with upper limbs alone.
Yes, sir.
The lower limb she is not able to move, so we have to
Yes, sir.
develop our own techniques of doing some exercise.
Yes,
In this patient, we have gone to the examination of the nervous system. These
Yes.
are the findings we found.
Higher mental functions were normal.
Yes.
Cranial nerves are normal. Motor system.
Can we summarize that this patient's cortex was basically normal,
Yes, sir.
and cranial nerve nuclei being normal, brainstem is possibly normal.
Yes, sir. Coming to motor system, bulk symmetrical, then tone hypotony on the right lower limb.
Yeah, so wait here. So apparently there was some asymmetry between the two limbs.
Yes, sir.
So the affected limb, the toes were short,
Yes, sir.
and it looked like a wasted limb, although on measurement there was no gross difference.
Yes, sir.
But limb was very much hypotonic. So what is tone? Can you define tone?
Tone is the partial contraction retained in the muscle, which is get by passive resistance to the movement.
So patient should be at rest.
Yes, sir. Patient will be at rest.
Okay. So can you tell some causes for hypotonia?
Hypotonia is seen in lower motor neuron lesion.
What is meant by lower motor?
Lower motor in anterior horn cell and distal to anterior horn cell.
Okay. And any other scenario where you can have hypotonia?
In myopathies.
That is part of the element, no?
Yes, sir. During spinal shock.
Spinal shock. So pyramidal lesion also you can have.
Yes,
Can
sir.
you name one more cause?
During deep sleep.
Cerebellar disease, you can have hypotonia.
Yes, sir. Cerebellar disease.
Tell me one extrapyramidal involvement where you can have hypotonia. Hypotonia with the extrapyramidal site of lesion. Chorea.
Yes, sir.
Chorea again you have hypotonia.
Yes, sir. Korea.
So comes to the power.
Coming to power, upper limb power is normal. Lower limb, hip, right-sided flexion, extension, hip abduction, hip adduction are zero, and left side is normal.
So name the hip flexors.
Yes, sir. Hip flexors are iliacus, psoas.
What is the root value?
L1.
2. Okay.
L.
Hip extension, it is a dominant muscle.
Hip extension is by gluteus Gluteus maximus. No, sir. Gluteus
hip abduction,
abduction by gluteus medius and minimus.
and a hip adduction.
Adduction is done by adductors, that is adductor longus.
Okay. So come to the power of the knee.
Power of the knee flexors of right limb and knee extensors of right limb are 3/5 and left sided is normal.
So which are the knee flexors?
Knee flexors are hamstring muscles and knee
And
extension
extensors are
quadriceps femoris.
root value of these quadriceps.
Root value, sir, L2, L3, L2, L3, L4.
Okay. Ankle,
Angle S1, S2.
dorsiflexion,
Yes, sir. Dorsiflexion, dorsiflexion, plantar flexion. Right side it is 0 and left side it is normal 5/5.
reflexes,
Yes, sir. Reflexes, abdominal reflex is absent. Then plantar, right side is extensor, left side is flexor. Biceps absent, triceps absent both sides. Supinator also absent both sides. Knee and ankle joints are also absent both sides.
So what do you make out of this?
Sir,
Okay, so this is a lower motor neuron lesion. Basically, only odd thing is patient has got extensor plantar. So why extensor plantar can be sometimes be tricky. Sometimes, if there is a symmetry between dorsiflexion of the big toe and plantar flexion, if you find the plantar flexion is 0, and even if there is one grade 1 extensor power, then you may get a false positive extensor. This is the only explanation we can give in this case.
yes, sir.
Otherwise, it is difficult to say. So here is a patient whose limb is flaccid
Yes,
and
sir.
it is paralyzed.
Yes,
So what are the common causes of a flaccid paralysis? What will be your differential diagnosis?
Then poliomyelitis, then LMN
That's good.
lesions, LMN lesions affecting the anterior horn cells. Then
Good.
rarely we get West Nile virus infections. Then spinal muscular atrophy.
Where is the lesion in spinal muscular atrophy?
Spinal muscular atrophy, lesion at anterior horn cell.
Anterior horn cell. That's good. Very good. Okay.
Then
So,
rarely
We can have patients with trauma to nerves or plexus, especially when one limb is affected.
yes,
Polio is one, Botley is another one, Guillain-Barré syndrome, and all conditions coming under anterior horn cell disease. So,
yes, sir.
acute flaccid paralysis. Let us go one by one. Can this be GBS?
Sir,
At the top of the picture, neuropathy GBS is there. Can it be GBS?
For GBS is usually resolved.
Okay, it's a reversible disease and it is
Yes,
usually bilateral.
Yes, sir, bilateral.
Can this be peripheral neuropathy?
Peripheral neuropathy, there will be sensory symptoms.
Rarely there is something called motor neuropathy, but commonly it is, when you say the term the peripheral neuropathy, just be bilaterally symmetrical.
Yes, sir. Yes, sir.
So can this be anterior horn cell disease like polio?
Sir, it can be.
Also vaccine associated, sometimes there can be polio-like illnesses. What about
Yes, sir.
muscle diseases?
Muscle diseases usually present bilaterally.
Usually
Present.
they present bilaterally. Very good.
Yes,
So
sir.
examples of diseases are
Then Duchenne muscular dystrophy,
Yes.
dermatomyositis, polymyositis,
okay.
periodic paralysis.
Okay. So there can be some neuromuscular problems again with the flaccid paralysis, like
Yes, sir.
myasthenia gravis. Can it be?
In myasthenia gravis will be exercise induced fatigue. That's not possible, I think, sir.
Not like a flaccid paralysis.
Yes, sir.
Not like a flaccid paralysis of single limb.
Yes, sir.
So flaccid paralysis of single limb is monoplegia-like picture. No.
Yes, sir. Yes, sir.
So there can be some other diseases also where there can be neuromuscular problems like
Yes,
falling
sir.
snake bite, cobra bite, tick paralysis, OP
Yes,
poisoning, botulism. Those things doesn't come here. So
Yes,
can this be some acute myelopathy?
acute myelopathy. Acute
Because
myelopathy.
you mentioned at the beginning there can be
Yes,
a
sir.
stage of spinal shock. So
Yes, sir.
can this be of that pattern? Where we have to consider transverse myelitis. If there's a level, it is not there. Multiple
Yes, sir.
sclerosis, again this is not the pattern. Multiple
Yes,
episode.
Yes,
Atom
sir.
is another one.
Yes,
And
sir.
ischemia to spinal cord. So such possibilities don't come here.
Yes, sir.
Okay. And we have got other diseases, systemic diseases producing
Yes, sir.
paraplegias like SLE
Yes, sir.
or ICU related problems like neuropathy or myopathy, critical illness
Yes, sir.
diseases. All of them will come as flaccid paralysis. So flaccid paralysis as per the anatomical side, nerves, anterior horn cell, muscles, neuromuscular junctions, spinal cord. This is a simplified diagram just to memorize. So coming to the patient we under discussion, here in the history that patient was okay at the beginning, illness, subsequently developed, indicates that possibly it's a infection like polio.
Yes, sir.
We cannot explain the extensor plantar, but there is an explanation given as I told you.
Yes, sir.
So, can you tell something about poliomyelitis?
Sir, poliomyelitis it's an viral infection.
Which virus?
Poliovirus, picornaviride
Okay.
family.
So, many of us may be getting this, but manifestations will be only very few,
Yes, sir.
0.5% only.
Yes,
So,
sir.
can you tell the pathophysiology of this illness? How do you get polio?
Yes, sir. It's a fecal-oral transmission, and it
Okay.
ascends through nerves to the CNS.
So, they say it is coming from the fecal oral route, water or food,
Yes,
and
sir.
they also multiply in GAT,
Yes, sir.
and they go for the symptoms and signs.
Yes,
So headache, fever, myalgia, vomiting. So many of
Yes,
us
sir.
may be having it, but we don't manifest it. So coming to the natural history, majority remain asymptomatic,
Yes, sir.
and many of us will be having GI symptoms, the flu-like picture, fever, headache, myalgia. They are called as abortive,
Yes, sir. Abortive.
and minority may be going for aseptic meningitis. What is aseptic meningitis?
Aseptic meningitis means there is viral meningitis.
What is the specific CS of finding?
CS of sugar will be normal. It will
That's
be
right.
clear.
Right.
Yes, sir.
Cell count?
Cell count will be normal or decreased.
Pleocytosis is expected in all meningitis, but
Yes, sir.
here to start with, it may be polys, subsequently
Yes,
may be polymorphs plus lymphocytes, later on
Yes.
maybe even lymphocytes alone,
Yes, sir.
and very few develop paralysis. Their number is very, very low.
Yes, sir.
So flaccid paralysis is a hallmark. There are ever so many conditions for flaccid paralysis in pediatrics, but adult practice, flaccid paralysis, rare, we commonly get it following trauma or people who had polio in childhood but going to adulthood.
Yes,
So,
sir.
there are different forms of polio.
Yes, sir.
Once you have paralysis, what are forms?
Paralysis forms.
This patient has got one
Yes, sir.
limb alone, so you call it
Yes,
a
sir.
spinal form.
Yes, sir. Spinal form.
Others get into trouble with the bulbar form,
Yes,
where
bulbar
they got
form.
respiratory failure,
Yes,
and it is those people who are taken up for ventilation,
yes, sir. Yes, sir.
and mortality is very high for them. It is the adults commonly who gets into bulbar.
Yes, sir. Adults.
Then we have bulbospinal, a combination of the two.
Yes, sir.
So basically, polio has got a biphasic pattern. they come with fever, GI symptoms, myalgia, flu-like illness, they become all right, and then they come with classical paralysis.
Yes, sir.
So it may be ignored fever, subsequently coming with polio. So what is post-polio syndrome?
Sir, post-polio syndrome is after the polio infection, the collective symptoms, group of symptoms are known as
Post-polio syndrome is a situation where you find somebody had polio, after many years being okay, it gets exacerbated, and many of them will develop findings like fasciculation. So whenever you have a patient with polio who deteriorates in course of time, you suspect post-polio syndrome. And when you have some waste muscles with fasciculation, what will be a differential diagnosis?
Then, sir, lower motor neuron problem.
So what is the condition producing fasciculation commonly?
Fasciculation is giving lower motor neuron disease, then myotonic dystrophy.
Which condition commonly? Which condition commonly you get fasciculation? The first condition you have to mention is
sir,
motor neuron disease.
Yes, sir. Motor neuron disease, sir. Yes, sir.
So somebody comes with features of motor neuron disease, element lesion, wasting,
Yes, sir.
fasciculation, airflexia, but give history of previous polio, then you have to suspect he is having post-polio syndrome.
Yes, sir.
So how do you diagnose polio? What are the investigations you have at home? Can you make a diagnosis by history alone or by other investigation?
We are fecal sampling and testing.
What will you test? So we have got PCR.
Yes, sir. PCR.
Full form of PCR.
Polymerase chain reaction.
What is it?
In this, we are multiplying the cells using this PCR technology.
Then
We can easily amplification identification of the organism.
So what are the samples you want?
A stool sample can be taken, or throat swab can be taken. Then
Blood.
CSF can be used.
Blood can be taken, CSF can be taken. So that's the only way to diagnose. There's only lab investigation available. And how do you treat these people?
Treatment is not available, sir.
But you have to do something for the patient, no?
So supportive treatment.
How do you support?
Rehabilitation. We give support.
Physiotherapy.
Yes, sir. Physiotherapy.
You have to give some devices to prevent deformities.
Yes, sir.
And as they become adults, you take them for corrective surgeries.
Yes, sir.
And there are tendon transplant, contracture release surgeries also.
Yes, sir.
So all element lesions can subsequently go for contracture.
Yes, sir.
So in those cases, you release the tendons or transplant some tendons such a way that they will be able to move around. These are the possible. This is a very difficult case, but if there is wasting classically, if there is classical history, no sensory loss, everything is fine except for upgoing plantar and absence of gross wasting.
Yes, sir.
Now, if you happen to take X-ray of pelvis of this patient, what will you find? What you will find is that affected side bone will be less grown. Growth of that side will be less grown that side. So one side will be big and other side will be small. Also, You may find the density of the bone is different on the two sides.